Orlando Medical Institute podcast.
Good day to you. This is a very long 330 slide, 4-part series on medications used to treat cardiovascular emergencies. The medications we'll talk about today are broadly divided into 3 classes of drugs. The first class of drugs we'll talk about are called sympathomimetics. The sympathomimetics are drugs that interact with and affect the sympathetic nervous system, which is one of 3 main nervous systems in your body. These 3 nervous systems are the sympathetic nervous system, the parasympathetic nervous system, and the enteric nervous system, which is thought to be an autonomous nervous system within the body. The first medication we're going to talk about within the class of sympathomimetics is a drug called epinephrine. Epinephrine is a sympathetic agonist. We're all generally aware of epinephrine. We feel it every day, and it's actually made in our adrenal medulla, which are part of a gland called the adrenal glands that sit on top of both of the kidneys. Epinephrine is a really potent alpha and beta adrenergic stimulant, but it affects the beta receptors a little bit more than the alpha receptors. This effect on the beta receptors a little more than the alpha receptors leads to a couple of things. A, it significantly increases your heart rate, it increases the cardiac contractile force, and it also increases the electrical activity in the myocardium. So what are the actual effects that you see from this? Well, the person's systemic vascular resistance goes up, the blood pressure increases, and a result of the increased contractility of the myocardium, you also see increased automaticity from the heart. In other words, the heart rate's going to go up. The effects that you see from epinephrine are not very long-lasting. The onset is pretty quick, it's less than 2 minutes. The peak effects are within several minutes, thought to be less than 5. It only lasts for 5 to 10 minutes, and the general half-life of epinephrine in the blood is only 3 to 5 minutes long. In other words, this is a very fast-acting, short-onset, short-duration medication. So what kind of conditions would you want to use epinephrine in? Well, it's quite intuitive. You would want to use it in any condition in which you want to increase the contractility of the heart or increase the systemic vascular resistance of the peripheral vascular system. And so some of these indications include cardiac arrest, such as an asystole, ventricular fibrillation, PEA, and also in other conditions such as anaphylaxis or reactive airway disease. The contraindications in epinephrine usage is really based off of the concentration that you have. So in epinephrine that is 1 to 10,000 or 1 to 1,000 dilutions, the total amount of epinephrine you have is the same, but the concentration is different. So the 1 to 10,000 concentration epinephrine you only use in people who require cardiopulmonary resuscitative efforts. In other words, you're using it for cardiac arrest. The more concentrated epinephrine, the 1 to 1,000 dilution, should only be used and administered either intramuscularly or subcutaneously in people who are having severe allergic reactive airway disease or asthma or anaphylaxis. Epinephrine is photosensitive, so you need to take caution in exposing it to the light. And it's also deactivated easily by alkaline solutions such as sodium bicarb. So in the event that you're using a 1 to 10,000 concentration, such as in a cardiac arrest, and you're also administering sodium bicarb on the same peripheral IV, you need to make sure that you adequately flush the line with, say, normal saline in between usage. Side effects of epinephrine are pretty well known. So if you can imagine yourself about to get ready for a presentation or a test, you're going to feel the effects of epinephrine. So you're going to feel some anxiety, some palpitations, maybe a little headache and dizziness, some flushing of the skin, and you might start to feel your heart start to pound, and that's because of the increased myocardial oxygen demand that is a result of epinephrine in your system. Some interactions of epinephrine, well, the effects of epinephrine can be intensified in patients who are taking antidepressants, and that's just because your nervous system can become a little more sensitive to the effects. The dosage and the concentration of epinephrine that you use depends on if it's an adult or a pediatric patient, and if you're using it for cardiac arrest or something other like anaphylaxis. So in adults, you're going to use 1 milligram of the 1 to 10,000 concentration epinephrine, either IV or IO, every 3 to 5 minutes. In cardiac arrest, you're going to be using 0.01 milligram per kilogram of the 1 to 10,000 concentration of epinephrine, either IV or IO. Note that you're not using the 1 to 1,000 concentration, you're using the 1 to 10,000 concentration in cardiac arrest in either adults or pediatrics. And once again, in pediatrics, the total milligram amount that you're delivering is 0.01 milligrams per kilogram. Because epinephrine is a chronotrope, you can use it to treat a patient who is experiencing symptomatic bradycardia. You do this by diluting 1 milligram of epinephrine into a 250 ml bag of normal saline, and that should give you a dose and a concentration of about 4 micrograms per ml. And if you target an infusion rate of about 2 to 10 micrograms per minute, you should be able to reach the desired heart rate. Now remember that in addition to being a chronotrope, epinephrine stimulates the myocardium, and this can induce ventricular irritabilities that can cause arrhythmias. And so you want to target your infusion rate so that you're bringing the patient out of symptomatic bradycardia, but you don't want to raise the heart rate enough to where you are starting to see arrhythmias such as non-sustained VTAC. The next sympathomimetic we're going to talk about is norepinephrine. Norepinephrine is a sympathetic agonist. Again, the sympathetic nervous system, like the parasympathetic nervous system and the enteric nervous system, is one of 3 innate classes of nervous system that you have. Norepinephrine is produced naturally in the adrenal medulla just as epinephrine is. In fact, it's made as part of the same pathway. It acts just like epinephrine does on the alpha and beta receptors. However, norepinephrine acts on the alpha receptors more strongly than in the case of epinephrine. So what does this mean if norepinephrine has a more profound alpha receptor response than epinephrine? Well, it means it's a more potent vasoconstrictor. So you would have more success in raising the blood pressure in a patient in septic shock if you use norepinephrine than epinephrine. And this is also the same case in cardiogenic shock as well. Norepinephrine tends to be better at constricting the renal and the mesenteric blood vessels because of that alpha response. And it's preferred over dopamine in cardiogenic and septic shock patients. Also, unlike epinephrine, norepinephrine tends to not be as arrhythmogenic and irritating to the myocardium as epinephrine. The pharmacokinetics of norepinephrine are very similar to epinephrine, except just a little bit faster. So the time of onset, well, it's immediate. Peak effects are less than 1 minute. It's quick on, quick off, so it'll last for a good 1 to 2 minutes per dose, and the half-life is about 3 or so minutes. Well, so what are the indications for norepinephrine? It's probably what you'd expect. So it's a first-line agent in patients in cardiogenic shock, and that's because norepinephrine has a lot less cardiac irritability than epinephrine. It's the first line for neurogenic shock. It's certainly the first line for septic shock, and it could also be the first line for really any kind of hypotension the patient is experiencing that's causing them to have symptoms, and it's not related to hypovolemia. Remember that you never want to use pharmacological agents to treat hypotension due to hypovolemia. It's much better to treat the hypovolemia instead. Just to really hammer home this point, you never want to give a pharmacological agent to treat hypotension primarily. You want to treat the hypovolemia, you want to treat the fluid loss or the blood loss. It would be appropriate to start both fluid resuscitation and a pressor at the same time if you felt it was clinically necessary. But typically what we do in the emergency department and pre-hospital is you start fluids or you start blood product resuscitation first before you start norepinephrine. Some of the precautions that we take with norepinephrine is driven from the pharmacokinetics of it and the specific attributes of the norepinephrine itself. So because norepinephrine is a potent alpha agonist and a beta agonist, it is really good at constricting blood vessels. And because it has such a short time of onset, you can theoretically drive blood pressures to be very, very high without you even knowing. So it's really important to measure the patient's blood pressure every 2 to 5 minutes. And that's really the only way that you're going to be able to tell that you're not overdosing the patient. As we just talked about, you should replace the patient's fluid loss before initiating administration. So if you squeeze a tank that has nothing in it, you're not really going to get a pressure response. So this is very analogous. You want to put fluid back into the venous system before you initiate contraction of that system to drive a blood pressure. Another thing with norepinephrine, and we see this from time to time, is that if the norepinephrine gets outside of the vein, you can experience tissue necrosis, and this is actually quite profound. And it could lead to necrosis, tissue loss of the area, but also digital ischemia. And so when you administer norepinephrine, you need to make sure that you are putting it in an IV that's proximally placed, large bore as possible, and you need to make sure that that IV is working well. Norepinephrine, like epinephrine, increases the myocardial oxygen demand. And so if you were to sit there with a norepinephrine infusion and it was too high, you might actually experience chest pain because of this increased myocardial oxygen demand. So you need to have some forethought and some caution when you're using it in people with pre-existing cardiac conditions. The side effects of norepinephrine are very similar to epinephrine, except because of those increased alpha agonist effects, you're going to see things like severe hypertension and, as we just talked about, increased myocardial oxygen demand. You might also see some of the other effects that's also associated with epinephrine, like headaches, dizziness, flushing, anxiety. Interestingly enough, if the hypertension goes too high on the patient, you might actually see a reflex bradycardia. That's never a good thing. That means that your infusion rate is much too high and the blood pressure is much too high as well. Norepinephrine can be deactivated when interacting with alkaline solutions such as sodium bicarbonate in much the same way that epinephrine is. However, unlike epinephrine, you are less likely to encounter a clinical scenario where you have to watch out for this interaction. Also, administration of norepinephrine in a patient who is taking a non-selective beta blocker, such as labetalol, might result in wild blood pressure swings. Beta blockers that are less likely to have an interaction are cardiac selective beta blockers, such as atenolol, esmolol, and metoprolol. These beta blockers have less an effect on the peripheral vascular system. The dosage of norepinephrine is 0.5 to 16 micrograms per minute, with a maximum dose of 30 micrograms per minute. You may need to vary the doses as time goes on, especially in septic shock patients, as these patients may become less responsive to norepinephrine over time. So, how do you create the right dosage of norepinephrine? Well, if you take 2 vials of norepinephrine, 4 milligrams each, you draw that up, you get 8 milligrams in total. And you take those 8 milligrams and you inject it into a 500 ml bag of D5 water, you're going to get a concentration of 16 micrograms per ml. Okay, because you took 8 milligrams of norepinephrine, you injected it in 500 cc's of D5 water. So you're going to get 16 micrograms per ml. If you set your drop rate to 45 drops per minute, that is all you need to give to administer 12 micrograms per minute. Now remember, this is just the mid-range dosage, 12 micrograms per minute. Remember, the range is anywhere between 0.5 to a max of 30 micrograms per minute. So you may need to administer far fewer drops or more, depending on the dose that you need to achieve the desired effect in your patient. The next sympathomimetic we're going to talk about is dopamine. The brand name of dopamine is Intropin. Like epinephrine and norepinephrine, dopamine is a sympathetic agonist. Dopamine is a naturally occurring catecholamine, and it acts on the alpha, beta, and dopaminergic receptors. It's actually the major catecholamine in the brain and is produced both in the central nervous system as well as the adrenal medulla. Its effects on the alpha, beta, and dopamine receptors is really dose dependent, and this is especially true of the alpha receptors. At the lowest dosages, dopamine mainly affects the dopamine receptors that are found on the renal, mesenteric, cerebral, and coronary vascular beds and actually acts to vasodilate those vascular beds. At medium dosages, the effects of dopamine on the patient can be difficult to predict, and this is because the beta effects begin to show. So you may start to see an increase in cardiac output due to the inotropic and chronotropic effects of dopamine. In other words, you might be able to see the contractility and the heart rate begin to increase. At the higher dosages, that's when you start to see increased play of the alpha receptor response. So at the highest dosages, you start to see an increase in the systemic vascular resistance due to the effects of the alpha response to dopamine. Dopamine is related to epinephrine and norepinephrine in that it affects the alpha and beta receptors, as we talked about. At the medium dosages, it affects the beta receptors. At the higher dosages, it affects the alpha receptors. Dopamine causes a positive inotropic effect on the heart, so it can increase contractility, but it's not as good at increasing the heart rate, at least as much as epinephrine does. And because of that, it does not increase the myocardial oxygen demand as much as epinephrine. Dopamine increases systolic and pulse pressure, which is the difference between the systolic and diastolic blood pressures, but there's usually less effect on diastolic blood pressure except on the higher dosages of dopamine that get those alpha receptors. The pharmacokinetics of dopamine are similar to epinephrine and norepinephrine, but just a little bit slower. So the onset is about 5 minutes or less, peak effects in about 5 to 10. Duration, it's pretty quick on and off, but not as quick as norepinephrine or epinephrine. So duration is less than 10 minutes. And then the half-life is about 2 minutes. I joke that the indications for using dopamine are when you've run out of norepinephrine, but it's actually true. Dopamine has fallen out of favor over the last decade, but you can still use it for symptomatic hypotension and especially in cardiogenic shock when norepinephrine is not available. You can also consider using it in patients with symptomatic bradycardia who are resistant to atropine or other measures. As a reminder, never use dopamine or any other pressor as a sole agent in treating hypovolemic shock. The first treatment of choice in shock is fluid or blood product administration depending on the shock. A special consideration must be given to patients with pheochromocytomas. Pheochromocytomas are small but unique tumors of the adrenal gland, one type of which may actually secrete dopamine. Giving dopamine to a patient with pheochromocytoma could worsen their condition. Dopamine, like epinephrine and norepinephrine, can worsen arrhythmias. Remember, whenever using the highest dosages of dopamine, 20 micrograms per kilogram per minute or higher, because it affects alpha and beta at that point, it has very similar effects to norepinephrine. The side effects, along with the unpredictable nature of patients' responses to dopamine, is one reason why it's fallen out of favor. Along with headaches, flushing, palpitations, nausea, dizziness, dopamine can also cause arrhythmias that are difficult to treat and may actually lead to the patient's death. Dopamine can be deactivated by alkaline solutions such as sodium bicarb in much the same way norepinephrine and epinephrine are. Patients can become very sensitive to dopamine when also taking MAOIs. Also, use caution on using dopamine on a patient with a seizure disorder, as dopamine can cause hypotension if the patient is taking Dilantin at the same time. Typically, dopamine comes in 400 milligrams diluted in a 250 ml bag of D5W or normal saline, and this creates a concentration of about 1600 micrograms per ml. Now, for bradycardia, your infusion rate is at the lower end, between 2 to 10 micrograms per kilogram per minute, But to treat hypotension, remember you need that beta and that alpha effect, so you're going to need the higher dosages of 10 to 20 micrograms per kilogram per minute. Remember that the maximum dosage of dopamine is 20 micrograms per kilogram per minute. Each vial of dopamine contains 200 milligrams, so if you draw up 2 of those vials and inject into 250 mLs of D5W or normal saline, voila, you get your 1600 micrograms per ml of dopamine infusion. So if you administer 30 drops per minute, that's how many drops per minute you need to administer 11 micrograms per kilogram per minute, which is a pretty medium dose to a 70 kilogram person. The last sympathomimetic that we're going to talk about is dobutamine. The brand name of dobutamine is Dobutrex. Again, dobutamine is a sympathetic agonist. Dobutamine is synthetic. It's not made in the body. It acts on beta-1 receptors primarily, but it's not as potent as other synthetic sympathetic agonists such as isoproterenol. Dobutamine has significant inotropic effects with little chronotropic effects. This means it will increase the contractility and improve the ejection fraction in a patient with congestive heart failure without increasing the heart rate. So it may be useful in the management of congestive heart failure when an increase in heart rate is not desired, and that's typically true of congestive heart failure. Many patients in congestive heart failure have a high heart rate, which is exacerbating their heart failure to begin with. The pharmacokinetics of dobutamine is similar to dopamine, but with delayed effects. So the onset is about 2 to 10 minutes. The peak effects is a little bit longer than the others. It's 10 to 20 minutes for you to start to see the effects of dobutamine. The duration varies depending on the patient, and the half-life is about 2 minutes. The indications for dobutamine usage is very specific. You only want to use it for short-term management of congestive heart failure to increase the cardiac output by increasing contractility instead of increasing the heart rate. As always, you never want to use dobutamine as the sole agent for hypovolemic shock or any other pressor for that matter. Also, because of its delayed time of onset of 10 to 20 minutes, dopamine may be a better agent to increase cardiac output in severe cardiogenic shock emergencies. Although dobutamine shouldn't do this, you could see adverse reactions including tachycardia and an increase in the systolic blood pressure, which is more common. Increases in the heart rate of greater than 10% because of its beta-1 effects may induce or exacerbate myocardial ischemia, and like the other pressors that we've talked about, PVCs and other arrhythmias are very common with dobutamine. I think you're starting to see a theme here with the side effect profile. So in addition to the lightheadedness, headaches, flushing of the skin, maybe some palpitations, dobutamine, just like dopamine, also can induce lethal dysarrhythmias. Dobutamine can be ineffective when administered to patients taking beta blockers, and also patients taking TCAs are more at risk to the side effect profile, including an increased blood pressure response while receiving the medication. The dosage of dobutamine is typically between 2 and 20 micrograms per kilogram per minute. If you take 250 milligrams of dobutamine and dilute it into 500 mLs of D5W, you should be able to adequately administer a dose range of 2 to 20 mics per kg per minute. So you take one 250 milligram vial, inject it into 500 mLs of D5 water, and you're going to get about 500 micrograms per ml. So if you administer 42 drops per minute, that's going to give you 5 micrograms per kilogram per minute to a 70 kilogram person, which is going to be about 350 micrograms per minute total. And that's about a good average dose of dobutamine. For the next section, we're going to look at a class of medications called adrenergic antagonists. Adrenergic antagonists do the exact opposite of the sympathetic agonists that we looked at on the last section. So these medications do the exact opposite of epinephrine, norepinephrine, dopamine, and dobutamine. These medications are called beta blockers, and what they do is exactly what they say. They block the beta receptors and sometimes the alpha receptors too. We're going to look at the most common beta blockers that are used out there, and those two that we're going to look at are called metoprolol and labetalol. But you need to be aware that there are other medications out there like propranolol, which was the first beta blocker made, atenolol, which is used to prevent dysrhythmias such as SVT, and esmolol, which is actually really interesting and is one of the shortest half-lives of any medication out there because after it's injected, it's actually metabolized by plasma pseudoesterases within seconds. And that medication you may actually see patients receive who are undergoing treatment for a hypertensive crisis for, say, someone with an aortic dissection. As I just mentioned, these medications antagonize the adrenergic receptor sites. Some target one specific type more than the other, for example, beta-1 versus beta-2. You need to know about them because they are used very frequently in emergency medicine and critical care, and you will be using them on a daily basis. The first beta blocker we're going to talk about is metoprolol. Metoprolol has a brand name of Lopressor. Do not get this medication confused with labetalol, which is a different type of beta blocker that we'll talk about next. Metoprolol is known as a selective beta blocker. Remember, it's one of the beta blockers that is not likely to interact with dopamine. Metoprolol blocks both beta-1 and beta-2, but is really selective for beta-1 at the lower to medium dosage range. Metoprolol will reduce the heart rate first and then may start to reduce the blood pressure. It is a useful medication in the post-myocardial infarction period when the myocardium is irritable and prone to arrhythmias. In fact, metoprolol has been proven effective in reducing post-MI ventricular fibrillation and reducing chest pain by reducing myocardial oxygen demand in the post-MI period. Metoprolol's onset is pretty immediate, with the peak effects in about 20 minutes. It lasts about 5 to 8 hours, and the half-life of metoprolol is about 3 to 4 hours. Indications for metoprolol usage are myocardial infarction with hemodynamic stability, and you may also use it to suppress narrow complex tachycardia that is not responsive or is unconverted by adenosine or vagal maneuvers. Metoprolol is also useful in helping control ventricular rate in patients with atrial fibrillation or atrial flutter, and in treating certain forms of polymorphic VTAC that's associated with ischemia, or caused by long QT syndrome or due to excess catecholamines in the body, such as from a patient with pheochromocytoma. What are some of the contraindications to using metoprolol? Well, you never want to give it to a patient who is bradycardic, such as a heart rate of 50, or who is hypotensive with a systolic of 90 or below. You never want to give it to a patient who has congestive heart failure or who has an AV heart block or is in shock. If you have a patient who is tachycardic due to a pericardial effusion, and in this case the heart rate is how the body is maintaining cardiac output, if you give metoprolol to blunt that patient's fast heart rate, you could actually precipitate hemodynamic collapse by giving metoprolol. So you need to be mindful of why you are giving the medication and what specifically you are treating. You also want to be aware that beta blockers can worsen hyperglycemia and worsen asthma or bronchospastic disease, as in a patient with asthma or COPD. In fact, giving a patient with moderate to severe asthma who is in exacerbation a beta blocker could put them into respiratory failure. While administering metoprolol, always make sure the patient's blood pressure, their pulse, ECG, and respiratory status are being monitored in real time. Discontinue metoprolol's use if the patient develops any signs of congestive heart failure, becomes bradycardic or hypotensive, or develops a heart block on the ECG, or develops bronchospasms, wheezes. The side effects of metoprolol, in fact, of many beta blockers, is similar to what we just discussed. So side effects include bradycardia, hypotension, lethargy, congestive heart failure, shortness of breath, wheezing, weakness, and many others too, including hyperglycemia. Metoprolol may interact with other AV nodal blocking agents, so it should not be given to patients who received other calcium channel blockers, and in general, actually give it with caution to patients who are taking any hypertensive medication at all. The dosage of metoprolol is 5 milligrams slow IV push. You can give up to 3 dosages 5 minutes apart as needed. However, you need to make sure that between subsequent dosages that the patient remains hemodynamically stable. The second beta blocker, which is very common that we'll discuss, is called labetalol, also known as the brand names Trandate or Normodyne. Labetalol, unlike metoprolol, is a non-selective beta blocker. It's a beta blocker that would interact negatively with dopamine. Labetalol will affect beta-1 and beta-2 equally, as well as block some alpha-1 receptors as well. The effect of non-selective beta blockade and alpha-1 blockade is that labetalol inhibits peripheral vasoconstriction, thus it causes vasodilation. Labetalol is a potent agent for lowering blood pressure because of this. The pharmacokinetics of labetalol is very similar to metoprolol. However, the onset of labetalol is a little bit longer than metoprolol. It is about 2 to 5 minutes. In addition, labetalol's peak effects are in about 5 to 15 minutes, which is similar to metoprolol, and the duration is a little bit less, it's 2 to 4 hours. In addition, the half-life is about 3 to 8 hours long. The indications to using labetalol lies in its broad beta effects. It can be used effectively to manage hypertensive crisis in which end organ damage is being caused. And that's in patients who are in hypertensive crisis and experiencing encephalopathy or altered mental status, they're experiencing chest pain, or they're experiencing renal failure. The contraindications to using labetalol are similar to that of metoprolol. You don't want to give it to patients who have asthma or bronchospasms, to patients who have congestive heart failure, have a heart block or an AV block, or are already bradycardic and hypotensive. Like in using metoprolol, patients receiving labetalol should have their blood pressure monitored, their pulse, their ECG, and respiratory status also actively monitored. And you must discontinue the medication if they experience any congestive heart failure or bradycardia, any type of shock, heart block, or bronchospasm and wheezing. This is repetitive but important to hammer home that the side effects of labetalol include bradycardia, hypotension, congestive heart failure, lethargy or tiredness or weakness, and even hyperglycemia. Just like any other beta blocker, including metoprolol, labetalol will interact with other AV nodal blocking agents. So it's important that you not administer labetalol to patients who have recently received any calcium channel blockers. And in general, just use caution in giving this medication to a patient who takes any antihypertensive medications at all. A typical dosage of labetalol is 20 milligrams injected slowly by IV over 2 minutes. It's important to assess the blood pressure before and after the injection, and then at 5 and 10 minutes after the injection. Additional administrations of labetalol can happen between 20 and 40 milligrams every 10 minutes as needed to titrate the patient's blood pressure to your desired parameters. But remember that you should never exceed the maximum dosage of 300 milligrams of labetalol. The second way you can administer labetalol is through a drip, and this is very common to give to patients who have hypertensive crisis in the emergency department or the ICUs. So you can take 500 milligrams of labetalol and dilute it in 250 mLs of D5 water. That's going to give you a concentration of 1 milligram per ml, and you can administer 2 milligrams per minute for a maximum dosage of 300 milligrams. Remember that as this patient is on a vasoactive medication, their blood pressure should be continuously monitored.
Orlando Medical Institute podcast.